episode of BlockchainFresh M.D. I'm Dr. Faith. And today I am super excited to have our guest here today, Dr. Suhail Chughtai. Dr. Chughtai is what I like to call a telemedicine consultant specialist, and he's got a wealth of knowledge to share with us today and all his success around building telemedicine. But before we get started, I want to thank Patient Tory Association, who is helping to build the framework around digital medicine and blockchain. So please visit them at patienttoryassociation.org. So Dr. Chughtai, let me introduce you first, and then please, I would love for you to tell the audience how you got started on this journey in telemedicine. So Dr. Chughtai is an orthopedic surgeon. He's a certified Microsoft specialist. He's the director of digital health and telemedicine at APPS in the UK, and what I like to call a telemedicine consultant with really a whole host of successes to talk to us about today. So please, without further ado, Dr. Chughtai, tell us about yourself and how you got started.
Thank you, Faith. First of all, I must appreciate you started doing an amazing job in getting the people from various places and talk about the services of telehealth. So I appreciate that initiative. I have heard one of your vlogs before, and I think that was emanating pretty credible information. So thank you. Thank you for giving me the opportunity. I'm an orthopedic surgeon based in London, as you said. My interest beyond orthopedic practice is connecting patient to doctor from a distance. And I've been doing so for the last 10 years pretty actively by designing telemedicine software. Telemedicine software can have various forms and shapes. They can be specialized telemedicine, they can be general telemedicine. So I do both. And then I go into the deeper layer of the project, like business models of telemedicine, like telemedicine at workplace, telemedicine at school, telemedicine in a box. So the business side of telemedicine, I provide through my team and myself as a consultancy service, and then as a technical service, designing a solution to a particular need and solving a healthcare problem. That's what we do, and that's what we do. I'm very comfortable with that role because it connects with my profession as well as with my other side, which is the technical side of medical profession. And I've sailed between the two ends of the spectrum. I enjoy it, and over the 10 years of time, in the past 10 years, I've managed to develop more than 20 international projects of telemedicine. I've loved it, and I feel that what I do is working, which excites me more. Beyond that, I'm into teaching of telemedicine. I've been, for a year or so, I've been teaching at the University of Health Sciences, Pakistan, where the Vice Chancellor, Professor Dr. Javed Akram, took the initiative and asked me to develop a department of telehealth and artificial intelligence. So I took help of my colleague, Professor Dr. Wallace, and myself and some other colleagues, and now we are teaching a master's degree course. We're going to start a master's degree course in telehealth in Pakistan. There is a lot more I can talk about, but let's talk about you first and your questions.
Yeah. So I find that very fascinating. I mean, you've almost hit telemedicine. I can't think of another angle that you haven't hit. You mentioned telemedicine in a box. What did you mean by that, telemedicine in a box?
We are designing a solution for army services where the soldiers in the front borders require medical assistance, not necessarily life-saving medical assistance, the one which will withdraw their post positioning and necessitate bringing them back to a center before their point. So we want to have a telemedicine box at the forefronts of the borders where they can use an encrypted internet service to connect that soldier who is not well but not critically injured back to the base to see if something can be done remotely. That is telemedicine in a box. And there is a second part of that where a motorbike rider using a briefcase can visit an elderly person at home who lives alone, and kids are either abroad or at a different city, and they can be those elderly people can be managed at home using telemedicine like a mobile hub and spoke service, where the spoke is mobile and hub is stationary in one of the cities in that country. So telemedicine in a box. It's evolving.
Wow, telemedicine, yes, making some incredible leaps and bounds in ways that I hadn't even imagined today. So on that light, I really want us to kind of talk about telemedicine in the way that you have, maybe touching on some of the barriers that you've had in developing this technology, because I'm sure you have had some. Again, I want to talk about the types of visits that patients might be more inclined to see a physician with telemedicine as opposed to other specialties. And then we'll close out with kind of the future, which you've touched on that quite nicely now, but we'll delve a little bit more into some of the future of telemedicine and where it's going. You are certainly no stranger to telemedicine, from even talking to you for 2 minutes here, and all that you've done with telemedicine in Pakistan. Talk to us about some of the challenges that you had getting this digital, healthcare technology to some of maybe the most remote areas there in Pakistan. What kind of barriers did you face with maybe hardware or Wi-Fi? Because I'm anticipating we're going to have some of those challenges here in the U.S. as we roll out.
I think it's a challenge to bring new technology, if not logistically, the mindset change. So we faced a whole range of troubles and problems. And in fact, I tell you one interesting point in this, that I designed my whole solution based on failures of other systems. And I worked my way backwards. That what didn't make a system successful, that was my checklist. And I wanted to bridge those gaps first before I could start working on the attributes of the system. So I thought, first of all, the technology is the physical barrier, that the bandwidth is not enough in certain remote areas. So what if there's no internet, but there is a 3G phone there? Now, in Pakistan, if you talk about this country, Pakistan, then we have penetration of 3G mobile handsets pretty much wide in the country. So it's affordable, it's easily available. So people do carry 3G phones, whether they can't afford many of the necessities in life, but mobile phone is taken as something they can afford, thanks to the government's infrastructure. So I thought, let's work under the 3G connection network speed without internet. So I fragmented my bandwidth to 356 kilobyte upload, maximum required to start a tele-conversation. I worked backwards, and then we managed to achieve that by micro-fragmenting the bandwidth and developing a local node, internet node in that particular region, in that particular geographical region, the country I meant, and then minimize the handshake time to 0.5 seconds. So that worked because, just like Netflix, where you allow the processor to do the part sharing, resampling of the signal, and then don't let the bandwidth be the bottleneck of the whole thing. So let the signal pass through, let it reassemble, and use the digital node nearby to reassemble the signal faster, like Netflix. So that worked. Then I believe that if you bring a digital product in a country, it's like any product where you have to force it to people and they may not need it. So developing a telemedicine culture was important for me, more than bringing a service. So I worked on that, and I think I started from doctors, teaching them, giving them small courses, and then engaging them more in the telemedicine's benefit for them rather than for the patients. And then vice versa for the patients, that why telemedicine should be useful to them. While I was doing it for the last 2 years, 3 years, two and a half years, and in the process, we developed telemedicine business places in Pakistan with pharmaceutical companies, with a company called Sehat Kahani, which was female doctors working from home. So I gave my technology to them and they started using it. Then the COVID happened. Then happened this big change. March 2020, the whole thing got necessitated, the learning got necessitated. people had to unlearn and learn and relearn. So I was asked to set up some system in which can connect patient and doctor from a distance, social distancing, lockdown. So I developed a telemedicine helpline for the country, which was supported by the governor of Punjab and then the vice chancellors of various universities, starting from University of Health Sciences Punjab, the largest university in Pakistan in medical sciences, and then the University of King Edward Medical College. Then all of this rippled. Universities, medical colleges started joining, and we had multiple telemedicine hubs. More than 500 doctors got trained in space of 10 days. While I was in UK, I was training doctors in Pakistan with the help of a local team and developing telemedicine hubs and hubs and hubs. And the governor supported very much. He even gave us transport to my teams because the lockdown didn't allow them to travel. And that rippled a chain of understanding that this is possible. Patients used to think, well, I can see a doctor on a software, not just a video conference, but a lot of other things like a Corona scoring system, patient education system. And that triggered a whole understanding of telemedicine in the country, that yes, I can do it. That barrier got lifted. Doctors, patients felt alike. And then the government, it's funny enough that I gave a presentation to a high-level official in government 3 months before the COVID, and I was given a kind of a semi-nudge. Yes, it's good, but they'll think about it. And you know what that means in diplomatic language. But 3-4 months after, I was invited by the same department to come and do the same thing. So the understanding changed from every level: consumer, provider, administrator. And that journey is fascinating. I'm writing a book on that journey. And
wow, that is so fascinating, Suhail. It sounds like you really kind of kept it really simple at first, focused on the things that were working, which sometimes as physicians and other professionals, we can make things really difficult. Figured out what do patients have. They mostly had a phone, right? And then worked your way up to government. I love that. I love that in how you kind of took that journey to overcome many of the barriers, giving a sense of confidence to people using the technology, because that's a big hurdle in how you did that. So, wow, thank you for sharing that. And I find that information really, really useful, especially where we are in the US today. We're a bit behind where you are. Telemedicine is not new here, but it's newly being utilized. And the pandemic is really something that has spurred that usage along in this country with lax in regulations, allowing clinicians to visit with their patients on Zoom or Skype, which prior to the pandemic, they wouldn't have been able to. And also patients just wanting to be a lot more safe in how they are kind of conducting their healthcare in this area, in this arena, I guess, of a pandemic. I want to, if I can, and you touched on this, you touched on the reaching telemedicine in some of the smaller populations, and you touched on what really resonated with me was this culture, this telemedicine culture you built. And I'm feeling like in this country, we are going to really need to build a telemedicine culture. Can you give us some tips on, from a clinician standpoint and also from a patient standpoint, how might we begin to build that culture?
Faith, this is a very interesting area, and being a clinician and a person who can, who sees a patient and tries to read the patient's mind and sensitivity while diagnosing a condition, all doctors do that. So it's a reflex of a doctor to think deeper than technology. And I'm blessed with the fact that I'm being a medical doctor, being a medical being a physician, At the same time, knowledge of technology, I can see where they meet. I can see the horizon very clearly, that where I can simplify the technology for my patients what they're scared of. They're scared of pressing too many buttons. They're scared of that I will be lost in technology. They're scared of, if I pay this doctor, will I be seen? They're scared of that, will doctor be able to see me? Can he hear me? Can I know who I'm talking to? So all these sensitivities I was able to address from a patient's perspective. And then the technology was no barrier, because I had some idea where I can open the gate. Now, it's important to understand one thing. Telemedicine is a home visit by a doctor to the patient. If we can convince a patient that, look, you're having a doctor at your home, how confident would you feel in your own home environment to see a doctor? You don't have to travel. That hassle is gone. You don't have to be in the waiting room where you're exposed to the higher germ count. You don't have to spend that much money to travel, or you don't have to take somebody with you to engage somebody who may have a day job. And then who is benefiting from it? It's you. You have a doctor in your home and you have a very relaxed environment. I mean, at my home, I feel I remember a lot more to say as compared to a situation where I have to go and I have to adjust with the surroundings. I'm distracted. Yeah. But here is this patient sitting at home, totally undistracted. And if you make the technology invisible to them, you are a winner. Faith, just remember, if you go to a doctor, do you remember which car you were sitting in? If you remember which car you were sitting in, you were distracted. And that is what I tried to do. I tried to make technology invisible to the patient. Patient remembers that I saw a doctor. That is where I base my success.
I love that. I love that. Making the technology invisible. That's key. And actually, in many respects, like you say, that visit, that one-on-one visit that we have in this setting of telemedicine or video chat can be much more engaging and intimate than we can, like you say, in a clinic with so many things going on, and they've just sat in a distracted waiting room, and then and there's just so much going on before they sit down. They've probably forgotten half of what they wanted to ask you in the first place. So you're right. There's a lot of, I would say, calmness to bringing forth this technology in this way and letting patients know that. And one of the keys to doing that is just making that technology very invisible.
So Faith, before you ask next question, I want to inject one little sentence to it. I saw a patient, I do my telemedicine clinic almost every alternate day. There was a lady who saw me the other day. She had a cat in her lap, and she was purring that gently while I was talking to her. And that gave her a sense of relaxation. I said, why you have a cat in your lap? And she said, I feel very relaxed. Now ask me anything you want. So she came into a trance of being very natural. When I was talking to her, it was therapeutic to have a cat in the lap for that woman. And she could do it on telemedicine, not in a real clinic. Please, Gary.
That imagery is that's amazing. That's really, really what we're talking about here. That's something you couldn't bring the cat to a visit at a clinic, but her comfort cat could be there at home with her. I think that's something that gets missed a lot. So thank you, Suhail, for pointing.
They can open the door for a postman. They can collect the mail while they're having a conversation with the doctor.
Yes. One other thing before we kind of move on to another shift in the conversation is I did notice that, because I had a chance to see some of the interviews that you've done, and I've just been fascinated with your work, where a lot of the clinicians, I would say, were somewhat kind of ready and prepared, having had telemedicine more firmly introduced, and kind of knew what job they had to do when the pandemic actually hit. One conversation that I heard that you had with your colleague, Somia Iqtadar, was around the pandemic hitting and how that clinicians needed to be much more innovative in their thinking and how they were going to deal with this unusual challenge. So I want to pause here for a minute so we can listen to this clip of Somia just tell us about that.
COVID-19 was an extraordinary situation. An extraordinary situation requires unique and innovative solutions. So it was a great challenge to maintain continuity of patient care, whereas you were at risk and your other patients were also at risk because of coming in contact with the infected people. I think telemedicine came as a one-stop solution for this problem, where we could conveniently look after our patients via video consultation and telehealth services. And at the same time, we were able to follow up the patients of other ailments like chronic diseases like diabetes or hypertension who needed a follow-up care. And at the same time, these patients were managed without exposing them of risk of coming to hospitals and clinics and catching the infection. During the COVID-19 pandemic in Pakistan, a lot of healthcare providers were also infected. About 6,000 people from the health sector got infected, which included doctors, nurses, and paramedical staff. And unfortunately, we lost more than 70 lives due to this virus. So I think it was very depressing. The people were scared, especially in the health sector, to provide healthcare to the patients because they thought that it was very risky to continue with their clinics and their hospital work. Telemedicine not only helped us because it was a convenient way to treat our patients, but also because it was available 24/7 and in any setting, and you could carry on with your patient care. So I think it was really helpful in treating the patients. But at the same time, I feel that if we had expanded this service to a mass level and more of our colleagues were using it, it would have been better and we would have lost less lives. I think now that we have found telemedicine as a new type of consultation forum for patients, it's going to go a long way in patient care, especially in clinics. On outpatient basis, it's very helpful. And I'm sure with innovation in the softwares, with new telehealth services and new softwares coming up, we will improve the patient care. And I can definitely say that telemedicine is the future of medicine.
I was really struck with that. She really put that in some really nice terminology. And I think I resonated with her when she talked about the fear amongst clinicians when this pandemic hit and how they had to go to work, see patients, and fear for their life, which, you know, all the years that I've been practicing medicine, it is really hard to imagine going to work, as stressful as it is, taking care of patients, trying to do your best, and then fearing for your life as well. And as you know, globally, we've already lost 7,000 plus healthcare workers. And this pandemic is not over, as you know. And we're also expecting another spike. So with all of that in mind, Suhail, what are some of your thoughts around telemedicine in keeping us all safe? And I want to phrase it in a way, because for me, it almost begs the question, should we be focusing and driving telemedicine almost in the same way that we do in wearing a mask and social distancing? And this could be a real key right now to keeping us all safe. So comment on that, please, Suhail.
I think you rightly inserted Dr. Somia's comments, and which was very clear that doctors are afraid to see the patients. Now, that is with the reason that infections think beyond COVID as well, people coughing badly on the face of a doctor, and then the doctor carries that pathogen for the next patients and for the family. So telemedicine has come as a blessing for the doctors as well. Physicians who are elderly, 60 plus with some medical condition, physicians who have to travel long distance from their clinic, from their home to clinic, physicians who travel during floods, rains, during country political upsets like road blockages. Now, those people who want to divide their time with the family, for example, a person who wants to look after an elderly family member at home or be around the family member, but want to carry on the practice. These are many examples. Female doctors who cannot work because of social pressures in certain countries, like Sehat Kahani is an example in Pakistan, where there are 25, 30 female doctors working from home. So the doctors have felt very connected to telemedicine, but the barrier to technology was, can I do it? Now that question got answered through COVID-19, necessitation of learning of telemedicine, where this question got answered when they had to do it. So I believe that wearing a mask is important when you're in a clinic, but having the freedom of seeing a patient through telemedicine, physicians must begin to enjoy it now. This is the time, if you haven't learned this technology, somebody who's younger than you, less experienced than you, will learn and will move ahead, and then you cannot be able to catch him or her. Telemedicine is going to be the medicine, and I don't say it without reason. There's a growing evidence that telemedicine is going to be the medicine. It's going to be the preferred way of outpatient consultation in the very near future.
I love the way you frame that. It's sort of like you're going to need to come on board this ship because it's going to leave the station with or without you. This technology is definitely here to stay, and it's going to be growing in leaps and bounds as it already has. I loved another interview that you did with Professor Angus Wallace, and his innovation in bringing telemedicine to a small community that he lives in the UK. He's been practicing telemedicine there, I guess, since 2011. And he was very sympathetic that patients had to travel long distances to see him in his small town, and how he could really take the lead in creating really innovative ways of connecting with his patients that they would resonate with. So I'd like to just play that clip of Dr. Wallace, and I love the way he kind of illustrates that for us.
Faith, I'm Professor Angus Wallace. I'm based in Nottingham in England, and I've been carrying out telemedicine consultations since 2011. I developed techniques for taking a history and carrying out an examination using telemedicine, and discovered that it was much more efficient, that I could see more patients more quickly, and I could come to a diagnosis in most patients quite easily. And as far as examination was concerned, we were able to modify parts of the examination so it could be done online. For instance, I'm a shoulder surgeon, and I got my patients to demonstrate to me how they could lift their arm, but also with a weight. It didn't have to be a very clever weight. We used a milk carton, and asked them to lift a milk carton. And we used a 2-litre milk carton, and that allowed me to understand whether the shoulder and arm was weak and how weak it was. You can modify your examination for people who have hip and knee problems by asking them to walk across the room in front of their smartphone, and that allows you to assess whether they're limping, how badly they're limping, and whether they might, as an elderly patient, for instance, need a hip or knee replacement.
So in watching that clip, I think the take home for me is we as clinicians can take the lead in helping our patients, as you say, feel more comfortable with the technology, making that technology invisible, sharing it with them in ways in which you did. You know, we've got some things, new things that we can do now. If you've got a cat and you want to have that cat at the visit, you can do that. I can connect with you. You can have much of the same health care without even leaving your house and staying safe now and into the future, because unfortunately, even when we're over this pandemic, it may not be the last crisis situation that hits us, and having telemedicine as a tool to use and feel comfortable using is going to be important. Would you not agree with that?
I think you've been very accurate on this matter. And telemedicine has brought a dimension which was visible, but people were shy to use it. I'll give you an example of your own place where you are in Atlanta, in USA. There are three, for Georgia, state of Georgia, there are three renal transplant centers. And people have to travel from southern Tennessee or maybe South Carolina to reach Atlanta City Emory Center. And in USA, there are 500,000, 450,000 renal dialysis patients. Now imagine those patients. There was a lady called Savannah. I was hearing the story of Savannah. She used to travel 4 hours from south of Atlanta to reach the city center 8 a.m. in the morning for appointment. So she used to have come in Sunday night. Now that was avoided once the telemedicine center was set up. That not every visit required a physical examination. And according to one of the nephrologists in Atlanta, Dr. Suhail, she said that not every patient requires a complete physical examination after the first one is done. So there is a growing evidence that you do not require a detailed physical examination to make a sensible clinical decision every time. And you can save patients a lot of hassle. So this is an example. I totally agree with what Professor Angus Wallace said. Look at the simplicity of raising a bottle of milk to do the abduction.
Yeah.
And in clinical examination, what you do is that if you have a lack of sensibility in one hand, you will ask, if this finger is out of 10 out of 10 normal sensation, how much is this finger out of 10? Did I touch my patient? Ask me this question. If you want to know what is the point of maximum tenderness, I don't put my finger on patient's shoulder. I will ask, where is the point on your shoulder? Just touch. Where is the point? Where is the most pain? And that is the point of maximum tenderness. So you have a visual examination. You have a visual parallel to a physical examination mode. And that is actually my next book as well, where I'm trying to suggest how can you replace the physical test with a visual parameter. So yeah, I think it's exciting. It's getting there.
So exciting, and I cannot wait to read those books, Dr. Suhail. So I'm really excited about that. So this has been such an interesting and enlightening conversation on telemedicine, on how to help patients become comfortable, clinicians become comfortable, and understanding that this is part of our future, and we just kind of have to rally around and kind of get a comfort level to move it forward. As we end here today, Suhail, I would love to spend just a few minutes talking about digital medicine in general and telemedicine, as it's really going to be the driving force. It's going to be very interesting what people are going to be, and you already know because you talked about what you'll be able to do with your phone. I mean, patients are going to be able to connect with the directory. They're going to have a video chat with their doctor. He or she may send them to a specialist. They'll be able to do that. They'll be able to connect data to them. Maybe they're following their glucose with an app they're using, so there'll be that interconnectivity. And then they'll be able to finally kind of upload a patient satisfaction form, and it'll be done relatively easy. And so there's no question that more and more patients and clinicians are going to be connecting with this kind of technology. But as we talk about that, we also have to be very mindful of security. And as we begin to share all this digital information, what kind of what's the word I'm looking for? What kind of impact do you think distributed ledger technology and blockchain is going to have on this, what I like to call digital explosion? And this is also a two-part question. Who do you think is going to be driving a lot of this technology? And I have a little bias here. There is a lot of talk about the silver tsunami, the 65 plus population that's growing in leaps and bounds. That population is expected to double by 2030. And no secret to many, they like staying healthy. And they do have some chronic problems that need to be managed. So from the standpoint of keeping your data safe and who you think is going to be driving this technology, give me your thoughts on all of that as we close here today, Suhail.
That's a very interesting question and a very sensitive one as well, from the patient's perspective and the data management policy designer's perspective. There's one HIPAA compliance, there's a GDPR compliance in UK and HIPAA compliance in America, but there's something beyond that called actually patient data file security. Now, blockchain has a non-crypto part of data management, where the smart contracts and the decentralized ledger and then the tokens are generated. So you have a gated access to certain information which patient can control. So I presented my paper in UK, and in fact, Krissa McFarlane, the Patient Chori CEO, she helped this concept which I presented in UK, that how can we have a folder level security based on non-crypto part of blockchain? Why not design a security system where the blockchain technology, which is already developed, why not use the advantage of blockchain technology into telemedicine by developing a folder system which has smart contract access, which has token management, and which has a decentralized hierarchy. So now the data coming to the clinician is omni-channel. It could be SMS, it could be an email, it could be a scanned document, it could be just a blog, and it could be a physical visit. So all of this omni-channel information to the clinician can be gated by blockchain technology. And I believe in that. We are working on a system which can take some time, but I'm sure as people become more and more sensitive, as the telemedicine consultations grow in number, the question of security of patients' files would come in play. And I think blockchain has an answer to that.
Thank you. And to the point of certain populations driving this technology, have you noticed any of that in Pakistan or in the UK? Or maybe better put, have you noticed the 65 plus population not having issues adapting to the technology?
I think I want to pay tribute to Steve Jobs. The touch screen is a self-learner. You learn so much if you don't have keyboard. Keyboard is a distraction. Keyboard is taken away. The touch screen is your teacher. So the elderly people learn very high skills by following colors. There's a thing called as color temperature of the screen. So you're attracted towards that area where you see an attractive color. And that could be the onset to your next screen where you want to lead your customer or client. So I believe that touch screen is going to change, has changed, and will be changing every technology we put on small screens, mobile handsets. Elderly people, they should have an option how to delete and control their data as well, which in my software design, I try to put that information that how to delete selective data or completely wipe out the file. And that should be, again, clearly visible to the patients as far as the security of the data is concerned for elderly people.
Wow. That is very, very fascinating. So this has been an amazing conversation with you today, and I don't know. I feel like we could talk forever about this, and I'm super excited. I can't wait to read your books when they come out. And for the audience that want to find out more about what you've been doing, I'm sure they can visit you at medicalcityonline.com.
And medicalcity.online.
Okay, perfect. And again, thank you so much for spending time with us and sharing with us your journey. And we look forward to meeting up again to talk more about this, because telemedicine is in its infancy, if you will. And so there's going to be a lot more unfolding as time goes on. So thank you.
I'm happy to be at your program, Faith. Thank you for giving me the opportunity to speak and express myself.